So by the end of this 40 minutes, you'll be able to explain basic concepts of covered California, the marketplace, focusing on Los Angeles County, review the rights, responsibilities, and decisions of impacted consumers, not just this year and next, but into 2015 when they're going to be doing their taxes. So that's any impacted consumer. And then we're going to consider the decision-making process for someone living with HIV, and we're going to discuss the role of the Commission. So we're going to do an overview and update of Covered California quickly, talk about rights, responsibilities, and decisions of impacted consumers. We're going to introduce 3 interactive cases, Pedro, Dwayne, and Tonya, and you're also going to get to share your opinions using audience response. We're going to go over different timelines and policy guidance clarifications from HRSA, which you have copies of in your packages. We're going to go over the different implementation roles of the Commission, DHSP, the State Office of AIDS, Ryan White clinician staff, the AETCs, and I want to thank the Drew AETC for helping put together today, and then you, whatever your role is, not just as a person that comes to Commission meetings, but as a person in your community, maybe as a parent as well. So we want to use the AIDS Education and Training Center as a neutral convener for meetings like this to help explain concepts around Covered California. And we also want to hear your stories. So what are your concerns? What are your questions in advance? Because we're going to try to get through this on time and keep people on time as much as we can, if you could write down your questions today, but also make sure that Maya from the Drew AETC, if you could stand up, Maya, so people know and maybe shake your arms wildly. So Maya is going to be the person who helps collect those stories and concerns so that we can not only know them as the AIDS Education and Training Center, but share them with HRSA and all of you. So lots of people to thank from UCLA, Wen Cao and AJ King, from CHIPS, from the PATC, Keisha McCurtis and Joel Peisinger, from Drew, Phil Meyer, and Maya Hilkantu. Also, I talked to people in San Diego because we have a border project to find out what's going on there to help us think across the state. So Susan Benson from the UCSD PATC, Carlos from DHSP, Aaron Fox, who's been incredibly helpful and will be on the panel, but also Courtney and Ann Donnelly up in the Bay Area. Benefits counselors, you're going to hear from one of them, John Riley, but I also been talking to Carlos Estrada at UCSD. The Ryan White clinicians, you're going to hear from Dr. Butler today, who works both at THE and the Drew PATC, and then Artis Mo, who works both at the UCLA PATC with me and at Northeast Valley. And we're going to have a consumer who's going to talk today, who's an impacted consumer. Michael Kelly, I want to thank him for coming and being patient with the time. And then the consultants that worked on this, Nicolay Mandel at the Target Center and Alan Gombrell, who's a consultant to HRSA in Washington. So let's start with the questions. So what best describes where you work? Mostly people from community-based organizations, 8% from a clinic, a couple people from health department. So welcome, everybody. What best describes what you do? Okay, great. And how many Covered California trainings or informational sessions have you already attended? Okay, so a lot of people, it's none, so welcome to your first Covered California training. But you can see that 13% have already been to 5 or more, so look forward to your expert questions after the panel. I feel I can explain Covered California to a friend. Okay, thank you for your honesty. So 45% said no, even though maybe some of them have been to a few informational sessions and a little bit, but we have 12% who say yes 100%. And so maybe some of those are the people that got outreach and education grants and have been through the training from Covered California. So really quickly, our AETCs had a meeting in Washington, and ONAP Director Dr. Grant Colfax was there, and he said, think of the continuum of care as being our North Star. A lot of us are used to calling this the treatment cascade for many reasons, including that cascades tend to go in one direction and people can go in and out of this continuum. We're going to increasingly be using the term continuum. And so if you look at who's this is the success story we've had nationally. You can look at it as a lack of success, but we have, 21 to 28% of people who are in care on meds and virally suppressed. And so we know in LA County, we do a very good job. We've got 26%. And if we can get someone into a Ryan White clinic, we do even better. So in 2009, we had 65% of people who were in care at a Ryan White clinic undetectable, and at 65% in 2009, and we even improved that to 75% in 2010. And I'm starting here just to remind ourselves that this is a lot of who we're talking about right now. So I just followed a presentation that really talked about lip migration and people that are going from healthy whale lay into lip. So today we're going to be talking about people who make more than 138% of poverty. So they're going to be going to a private insurance plan in covered California. So many of these people are doing really well in Ryan White clinics. So one of our mantras today, and it has to be, I think I'm hearing some of the concerns about, we've got less than 60 days until the market opens, but one of our mantras today has to be, don't fall out of care. Right? Don't let anything let you fall out of care. Fear of a co-payment, fear of co-insurance, fear of a deductible, don't fall out of care. Come back to me, whether me as a friend, me as a benefits counselor, or me as a clinician. So focusing on the Patient Protection and Affordable Care Act, this is really the biggest change to our healthcare system since I was a year old. So it's really been a long time we've had to change this big. And it's not new. I mean, it was signed into law in 2010. The Supreme Court upheld it in 2011. And so now in 2013, October 1st, we're going to have the exchanges open, and for insurance starting January 1st. And so what did the Affordable Care Act do in 2010? Well, importantly for our discussion, it eliminated pre-existing conditions exclusions. It expanded Medicaid to non-disabled adults with incomes up to 138% of the federal poverty level. It created subsidies to purchase private insurance through exchanges for people with income 100 to 400%. And what we're going to talk about today, it's in red there, is it created more eligibility for people with HIV for both Medicaid and for the marketplaces. So our state-based marketplace is Covered California. It's coveredca.com. It's not .org, it's .com. It is getting private insurance, and this is what the website looks like. So I put it there in red if you could see, because I think Keisha McCurtis and I did a screenshot for some border trainings we did, and it said 239 days until insurance, but as a couple people have already pointed out, less than 60 until the marketplace opens. But I think that's another mantra that we have to have for people, is just because the marketplace opens on October 1st, there's no need for you to rush and enroll on October 1st. Right? So you're going to want to think through what would the checklist be for a person with HIV, who are the people they're going to want to talk to, how do we make sure that we get through they're getting the optimal decision-making process for them. And so a lot of this discussion is based on the federal poverty level. So I know people are so used here talking about FPL and different designations for FPL. This is a chart of the federal poverty level. You can see there that for a family size of one, an individual, and my examples today are going to be for an individual, but you can look at different family sizes. The federal poverty level in 2013 is $11,490. So it's important to remember that number so you can reference it in your mind, and then to also remember that 138% of the federal poverty level is between $15,000 and $16,000. So people making less than that, they're in healthy way, likely transitioning to Medi-Cal managed care. People making more than that are going to be going to Covered California. So this is everything in a slide. So I'm going to try to maybe just spend 2 minutes on this slide. And if you can see my laser pointer, so if you're making less than 138% of poverty, we know you're going to be going in 2014 to Medi-Cal. If you make more, you're going to be going into Covered California, and if you make less than 400%, you're going to get immediate or deferred, it's up to you, premium tax credits to help you pay your premium. If you make less than 250% of the federal poverty level, you're also going to get cost-sharing subsidy helps from the federal government. Okay, we're not talking about help from Ryan White yet. We're talking about help from the federal government. And you're going to get those cost subsidies if you're in the silver plan. Okay, so this is everything in a slide. You're going to get, if you're making in LA County between 138% of to 400% of the federal poverty level, which is $15,856 to $45,960, you're going to get help with your premiums from the federal government. Okay? If you make less than 250%, in addition to that help, you're going to get help with cost-sharing subsidies. In other words, your co-pays, your co-insurance is going to be less, and your deductible is going to be less. So if you think about nationally, people living with HIV that are getting Ryan White funded services, we're not talking about a lot of people who make more than 138% of poverty. So you can see 100% of poverty or less, it's about 70% of people. So more than 300% of the federal poverty level is only 3% nationally. 200 to 300% is only 6% nationally. And quick audience response question. I have already visited the Covered California website and used the premium calculator. So you've done both of those things. Okay, so 77% have not yet. So that's something really to, you can go back and you can start playing with the calculator and start looking at what the premiums would be for somebody, again, not living with HIV, who's not going to get other help. What would an impacted consumer who's not going to get other assistance, what kind of assistance would they get? So I'm going to ask you, what do you think the penalty is for someone who should have health insurance but didn't get it in 2014? Okay, so 29% don't know. Thank you for the honesty, and thank you. 32% think there's no penalty the first year. And the correct answer here is that it's a tax penalty of $95 or 1%, whichever is greater. Okay, so the tax penalty phase-in is that when, if for your 2014 taxes, it's going to be 1% or $95, whichever is greater. So your 2015 taxes, which you do in 2016, it's going to be 2% or $325 is for individuals, whichever is greater. And you can see it goes up to being pretty significant when you're filing your 2016 taxes. Thank you. And goes to 2.5% or $695, whichever is greater. And so you can see that for a lot of people in the room, we weren't aware of this. And this is why today's presentation was entitled Getting Everyone on the Same Page. So some of the things we won't have 100% clarity on the answer today, but at least we're on the same page about what the issues are. And for example, for this, where we definitely have clarity, we know what the answer is, we're all going to be on the same page. So there's 19 different rating regions in the state of California for insurance. We're the only county that's divided into 2 rating regions, and there's 13 different private health plans that people can go in and sign up for. We have 8 of them in LA County. So LA County is divided into 2 rating regions, rating region 15 in the north and rating region 16 in the south. So this is not to scale. Don't think that the north is only the woods and places outside of the South. So I just talked to someone from Barbara Boxer's office who shared with me that he lives in Eagle Rock and he's in 15. So you can see the different plans. This is someone who lives in rated region 16, that southern region, who's 40 years old, who's single, and he's unsubsidized. So he's making more than 400% of the federal poverty level. So he chose a silver plan. He went to the website. He's unsubsidized. He makes more than 400% of poverty. We're not talking about HIV yet. And so you can see HealthNet, the HMO is $242, Anthem HMO $259, Molina Healthcare $259, LA Care $265 HMO, Blue Shield PPO $287, Anthem EPO is $299, and Kaiser is $325. So Kaiser is actually the most expensive plan here for this person in LA County. And the reason the plans Anthem and Molina are asterisked is because they're the second least expensive silver plan. So that's what the subsidies are based on.
Tom, I just wanted to, I was out of the room, I was getting a phone call, but I understand you said 1,500 people in LA County will be in Covered California. That's not an LA County figure.
Okay.
It is more related to the Ryan White system, but I wouldn't even want us to stick to that figure for the Ryan White system because we're constantly defining the data and figuring it out. It's going to be much larger for LA County, and frankly, I couldn't tell you what that number is.
Great, thank you for that. And let's move on to rating region 15 then, 40-year-old single, unsubsidized. You can see that rating region 15 is actually less expensive than rating region 16.
Tom, we've got a question out here. Anthony.
Just for a point of clarification, when we talk about subsidies for the silver plan, and you said the second lowest silver plan, would that subsidy be based on the second lowest silver plan to be applied to any plan that the client would choose, or only be applied to silver plans?
It's so for the premium subsidy that helps you with your monthly payment, it's applied. The second lowest silver plan subsidy is applied to the other metal groups, and we're going to talk about that in a second. It may be helpful with the time restriction to write down a question, and then maybe we'll answer it, and then after the panel we can take questions, because I'm concerned for a clinician that needs to get back to clinic. Okay, so if you look at the impact of the immediate tax credit, so this is a 40-year-old, and I'm going to give him different income. So this is the 40-year-old, he's in rating region 16, and if he makes 400% of the federal poverty level or more, he doesn't get any tax credit. So that's going to be the full monthly premium payment. And I just chose here HealthNet because it's the least expensive in LA County's plans. So if that person makes 200% of poverty, which is 11,490 times 2, they are going to get a tax credit. And so their payment's going to go down to $103 per month if they choose the immediate tax credit. And then if they have 150% of poverty as their annual income, which they're predicting for 2014, it's going to go down to $40. So in rating region 15, you can see it's even less expensive, and so HealthNet would go down to $27 per month for somebody who makes 150% of FPL. This is for anybody. We're not talking about people living with HIV. And so you can look at this on the Covered California website, and I've got a bunch of colored copies of this so you can see it, but you go through the bronze plan, the silver plan, the gold plan, and the platinum plan, and shows the different copays for those plans in general, and which ones are subject to the deductible and which ones aren't. We're going to talk about that a little bit more. It also goes through the sliding scale benefits within the silver plan, and maybe that's what the question you were getting at is, you have to be in the silver plan to get the cost sharing subsidies if you make less than 250% of poverty. Okay, so that's when you go to a visit, your copay is less. So remember that all of these income figures that we're using are calculations projecting your income forward. Okay, and so you're dealing with your taxes, and it's your taxes that will reconcile everything. So if I predict that I'm going to make $30,000 and I get some help with my premium, and I actually in 2014 only make $25,000, at tax time I'm going to get some money back, and vice versa. If I underpredict my income and I make more, and I got that premium support each month from the federal government paid to the healthcare agency, I'm going to owe taxes. So these would be important conversations for people to have for everybody. So if you look at the Covered California network, and you're going to be hearing a lot about Covered California in radio and TV and from the people in the room who've been funded for outreach and education, JWCH, Being a Star, the Gay and Lesbian Center, lots of places are gearing up right now to do a lot of outreach and education. And then you're going to hear, for someone to get enrolled in care, they're going to have to go to a certified enrollment counselor starting October 1st, and those grant mechanisms are just getting started right now. So how do anyone get information about health? This says more patients use Google for health, so I had to change my name to Dr. Google just to keep my practice open. So I think people really use the internet. So the internet is a primary source of people getting information on anything. But then there's other sources of information. I think the LA Times has been doing a good job. They're reporting on keeping us up to date. There's going to be different news agencies that have different views on the implementation of the Affordable Care Act. And then also there's research that shows, for example, young men go to their mom. So young men will, when they have to make a decision about whether or not they're going to buy insurance, one of their top sources of information is their mother. So if you look at the application process for becoming a certified enrollment counselor, so right now you have to get set up to be a certified enrollment entity. We've actually gone through that process for our unit, our office at UCLA, to see if we want to become certified enrollment counselors. So certified enrollment counselors will go through a background check. They're going to get thumbprinted. They're going to be part of an entity that could get paid $58 for enrolling people. So all of these are opportunities for possible fraud. So we're also going to have to be really aware of what people out there have malintent and might be wanting to defraud people at this time. So let's go through some terminology really quickly. So premium, that's what you pay each month for your health insurance. Deductible, that could be a set amount each year that you have to pay before your health insurance kicks in. The platinum and gold plan have no deductible. The silver plan has a deductible that gets part of that sliding scale and gets smaller the lower your income. Copay is a fixed amount for a healthcare service that you have to pay once your deductible is met, and coinsurance is expressed as a percentage. Your total annual out-of-pocket expense is the most you can spend each year on healthcare. Adding those up. And your premium assistance or tax credit is something that I said comes from the federal government. It goes straight to your health care person if you take it up front. It can be immediate or deferred. And then cost-sharing subsidies are those things that I described at point of care that makes it less expensive to seek care. They're within the Silver Plan for people who make less than 250% of poverty. And then the final term is reconciliation. So when you file your taxes, if you made more than you projected or less, you're going to have to reconcile it. So as I mentioned, the platinum and gold plans don't have a deductible, and these total cost percentage, these 90, 80, 70, and 60% is an actuarial projection assumption. So that's all the people in the platinum plan on average are going to pay, the insurance is going to pay about 90% of their medical expenses, 80% in gold, 70% in silver, and just 60% in bronze. And consumers are going to have to understand the difference between an HMO, a PPO, and an EPO. I'm sure a lot of us are used to going to a health maintenance organization where they've contracted with the HMO and we have to stay within that network. The only thing they'll pay for is emergency care outside. Preferred provider organizations where you can go through a list of different preferred providers. If you stay within that network, your care is less expensive than if you go out, but if you go out, you can still get it reimbursed. And exclusive provider organizations where they create their own network of providers, doctors, and hospitals. So for example, UCLA is an EPO with Anthem. And so we could spend a lot of time on this slide comparing the Ryan White core services with the ACA essential health benefits, but that's going to be a really big role for the commission. I've already talked to Carlos really briefly about this because he said, you know, there's a lot more that's covered in Ryan White and LA County that's not in this slide, so he can make some comments about that during the panel. Craig, you said you might want to make a comment about this?
I'll defer to Carlos.
Okay. But that's going to be a major role, is looking at the services that aren't covered in the qualified health plan's essential health benefits. And remember, too, that we have to be really cognizant of Ryan White as a payer of last resort. And so we've got some recent HRSA clarifications about how this will work, and they're clarifications. I mean, it's not like they're new policy. And so you've got a copy of those in your folder. And so here's one of them for Medicaid, but you've also got a number of policy clarifications around patients who will be going to private insurance. And basically, if I were to just highlight a couple of the things that I thought were important, is that you can't pay someone's penalty with Ryan White money. That should seem fairly obvious. And that the expectation is that a patient that qualifies to get affordable insurance, especially with the assistance they're going to get from Ryan White, should be doing that. So let's look at a case really quickly. So Pedro is a 28-year-old phone sales representative who estimates that he'll make, in 2014, $12,000, or about 105% of the federal poverty level. He lives and receives his care at a Ryan White clinic in Rating Region 16. He has been in the U.S. legally for 7 years. He also receives dental care and case management services at Ryan White, and he wants to stay at that clinic. Under the Affordable Care Act, will Pedro be required to purchase health insurance or pay a penalty? I know lots of people know the answer, so don't say it. Just go ahead and vote. Okay, he won't have to because he qualifies for Medi-Cal. Remember, he makes less than 138% of the federal poverty level. So let's look at Dwayne. Dwayne is a 40-year-old phone sales representative who estimates in 2014 he's going to make $19,000. He lives and receives he lives in and receives his care at the same Ryan White clinic as Pedro in Rating Region 16, where he was born. He also receives dental and case management services through the Ryan White Care Program, and he also wants to stay at his Ryan White clinic. Under the Affordable Care Act, will Dwayne be required to purchase health insurance or pay a penalty? Exactly. So he will be required because he makes more than 138% of poverty, and so he will get help with his payments and his co-pays, not just from the federal government, but also from Ryan White. So if you look at Dwayne, and you don't consider his HIV status, you just look at him as a citizen who's going to get help from the government, he would be eligible for a federal subsidy. And even though the insurance on the calculator, the estimate would come up on Covered California's website is $294, he's only going to have to pay $75 because he's getting that assistance immediately from the federal government, and you can see that his co-pays are actually going to be a lot less. And so once again, I'm going to show you where this information comes from, because we had reviewers like Phil Meyer at Drew go through this. He's like, where did you find this information? I couldn't find it on the website. And so you actually go to the Covered California. You can Google this and just pull it up. And you can find, for example, that the silver plan copays are on page 4, that the copays by metal group are on page 5, and then our rates for our 2 rating regions in 15 and 16 for LA County are on page 81 and 87. So what other help can someone living with HIV expect to get? So like Dwayne's going to get help with that monthly payment. So we have an existing program called the Office of AIDS OH-HIPP program, Health Insurance Premium Program. So are you familiar with that program? Yes, 100%, yes, somewhat, yes, a little, or no? Okay, great. So a lot of people aren't. And so we're going to have to really become familiar with that program. These people, that's going to be a huge thing for them to know about, is you can get help with your copays and your premiums, and it's going to be significant. And so that's why I asked John Riley to join us today, because he's an OH-HIPP enroller and can explain how that currently works, and we're going to get some updated guidance on how it will work when the exchanges are open. So current eligibility for OH-HIPP, remember, Office of AIDS Health Insurance Premium Program, you've got to be enrolled in the AIDS Drug Assistance Program. You've got to be a California resident. You have to be 18 years or older. You have to have an adjusted gross income of no more than $50,000. You cannot be enrolled in Medicare, full scope, or free Medi-Cal, or the low-income health program, Health UALA. And you have to have or plan to get a comprehensive health insurance plan with prescription drug benefits. Okay, so that's the existing program that's going to be modified, but it's going to help someone like Dwayne with his payment and with his HIV-related copays, including for prescriptions that are on the ADAP formulary. So because we've got the Combined Planning Council, I thought I'd give a case of Tonya. So Tonya is a 52-year-old hotel worker born and living in South LA. She thinks she's going to make about $21,027 in 2014, which is 183% of the federal poverty level. She currently has no health insurance. She says she always wanted it but could never afford the rates for someone my age. She's not seen a doctor in years, but sometimes goes to an urgent care clinic to get antibiotics. She would especially like health insurance now, as she recently inherited a home from her parents, and she worries that just one ER or hospital visit could bankrupt her or cause her to lose this home. She believes she's in good health, and she feels great. But Tonya doesn't know that she's living with HIV and hepatitis C. So let me ask you, so Tonya signs up and chooses a qualified health plan and a primary care provider in one of those insurance groups we just went through. Do you think she will be tested for HIV as part of her routine care with her provider in 2014? Okay, I think a lot of people are being optimistic. So I have to say, you know, maybe if she's going to Ultimate, or maybe if Northeast Valley rolls out with Gilead the routine testing, but I think in most of those health plans, you know, we're not going to see routine HIV screening as recommended both by the CDC, 7 years old, those recommendations now, and is also recommended by the U.S. Preventive Services Task Force, grade A, so they can bill for it. So there's really no reason why she shouldn't be routinely tested for both hepatitis and HIV. But I have to say I agree with the no's that she probably won't be. And so we, as people thinking about those people living with HIV that don't know it, have to maybe invite the health plans here to talk about, will people new to insurance be routinely screened for HIV? So that's a role we can take on. So do you think she'll be tested for Hep C? Okay, so I think that you're right. I think she won't be. But interestingly, if someone's tested positive for HIV, they'll likely be tested for Hep C. So that one thing will lead to another, but both of these should be done. This is another CDC guideline. All baby boomers should be tested routinely for hepatitis C. Okay, so now do you feel like you can better explain a little bit Covered California to a friend? Okay, good. So we nudged people up, which is exactly what we were hoping to do. So there's a lot of great resources that are out there. HRSA has a page which includes an email so that they want to collect questions. So anything you send to Maya at Drew, we're going to share with HRSA. The Target Center has great resources. Nicolay Mandel and Alan Gombrell have really been working on updating that, and they're updated every day. I know that those of you that work in Ryan White clinics are used to using this. And so once again, you have Maya's email in your packages.